Dr. Vučković is a general surgeon, but he's also a groin pain specialist who is currently working at Adductor Clinic as a director of their groin pain center. So he's going to help today lecture and give us some advices about the diagnosis and treatment of the groin pain. The headline of today's lecture will be the surgical treatment of groin pain in athletes. So after the lecture is performed, you will have the opportunity to ask questions directly to Dr. Vučković. So just for the people that are here for the first time, when you click on the Manage Participants option that is on the bottom of the screen, the window will appear and you will have the opportunity to click Raise Hand. When you click it, I will get a notification that you want to ask a question, and I will ask for your name in order to ask that question to Dr. Vučković. So we will start now with the lecture. I will just mute the microphones of the participants that are coming in during this. So Dr. Vučković, you can now continue with your information.
Thank you very much, and thanks for everyone for joining today. Real support for Belgrade Sports Medicine E-Forum, and great initiative, and I hope you continue with this success. And without further delay, I'll just start the presentation. Okay. Okay. Surgical approach to groin pain in athletes. No conflict of interest, and we can continue. As you said, I work in Adductor Hospital, which is a sports medicine orthopedic hospital. I'm the only general surgeon there, and in charge of sports groin pain center that we have. And since we're talking about groin pain, also known as the Bermuda Triangle of sports medicine, or the no man's land, as other people want to call it, because it's a topic that overlaps different specialties. General surgeons treat inguinal pathology, orthopedic surgeons treat the hip, and sports medicine physicians, physiotherapists focus on soft tissues and thigh muscles. And here we need to have a more broad view and to see the whole picture. And like the father of modern medicine, Sir William Osler, said, medicine is a science of uncertainty and an art of probability. And it's really true when it comes to groin pain. So how severe is this problem? We know from epidemiological studies that up to 20% in men in football and 14% in women can have groin pain during a football season. But this is just a tip of the iceberg, because if you only check athletes who miss games and training sessions, you will miss 2/3 of people with groin pain, which is proven in the recent studies. And the story of groin pain is a long story. It started in 1932 when Spinelli first described adductor pain in a fencer, and then Bandini in 1949 in football, continued to Nešović in 1967, who did the first inguinal repair on a football player. Gilmore in the 1980s was the first one to publish his work in Anglo-Saxon literature. And then there was a 20-year gap, and in the last 25 years, there was an explosion of research. And in 1997, Cugat from Barcelona proposed the dynamic osteopathy of pubis theory. He was the one who treated patients mostly with adductor tenotomies, orthopedic surgeon. And at the same time, Professor Holme from Denmark came up with his adductor exercises program for conservative treatment for adductor pain. Then Myers, Bill Myers, #1 surgeon for groin pain in the USA, published his work on core muscle injury theory, and Ulrike Mušavek published her papers on surgical treatment of inguinal pathology and early return to play. So since 2000, we have a lot of research in this topic, and it's a hot topic in sports medicine, and this is why we want to focus on this a little bit more. My colleague Andreas Cerner published a paper in 2015 on where he showed that study quality on groin injuries is very low. And the stunning fact was that on 72 studies that were presented here, there were 33 different diagnostic terms used, which means people are comparing apples and oranges. They didn't know what they were talking about when they compared their work. So there was a first attempt to reach a consensus terminology in Manchester by hernia surgeons there, and they came up with the term inguinal disruption. But again, they were only focusing on inguinal pain and missed out a lot of other pathologies. That's why in 2014 in Aspetar, we had a consensus meeting with 24 experts in groin pain coming together. And what we came up with is 3 groups of problems. One is defined clinical entities in groin pain, which is what we usually call groin pain in athletes. Second is hip-related groin pain, which is in close proximity, and then other causes for groin pain, all the other intra-abdominal pathology, urogenital, and even cancers. So defined clinical entities for groin pain can be grouped into adductor, inguinal, iliopsoas, and pubic-related groin pain. What this means is these are not diagnoses. This is just the first step into communicating in the right way and making sure that we know what we're talking about. After this, there was another consensus statement in Italy. Basically, they had 63 potential causes of groin pain with 11 different categories, but if you go further down, it can also be grouped in what we already did. So there's a lot of work ahead of us, first for coming to the correct terminology so we can compare our work, and then reaching the proper diagnosis. In our retrospective study in our clinic in Aspetar, on 100 athletes with groin pain, we found out that in 44% of athletes, there were multiple causes for groin pain. So it's not only one diagnosis, it's not so simple. But adductor-related groin pain in our series was the most prevalent in 61% of the athletes. So the first step when you come to diagnosis is the proper medical history. If you take nice sports medicine related questions, you can already have half of the story there. And I will not go into details, you already know about this. But then physical examination is the second half, and it consists of palpation, passive stretching, muscle resistance. And if you know your anatomy, and it's pretty easy to perform all these resistance tests and palpations, and you can pretty much reach a diagnosis, or at least what part of the body is mostly affected. Do we need imaging? Yes, it's always helpful, but you have to be cautious when it comes to imaging. In adductor-related groin pain, it's useful to do an ultrasound on an MRI. Inguinal-related groin pain, ultrasound, dynamic MRI, or CT. But this is mostly to rule out any other pathology, and for me, it's my preference is ultrasound because it's easily accessible and not expensive, and it can be used for all the entities that we talk about. But it's also been proven that by Professor Pajanen from Finland that 48% of non-symptomatic athletes can have some positive findings on pubic bones on MRIs. So don't jump to conclusions when you see patients with some positive findings, because that might not be the cause of the problems. It's also replicated in a study from the US on also ice hockey players, where up to 77% asymptomatic players have positive findings on their hip scans, and altogether 64% have false positive findings. So treat the patient, don't treat the image, like we used to say. Maybe in the future we will have better imaging modalities, and then our life will be easier, but until then rely on history and the clinical examination. So number one problem here is adductor-related groin pain, and it is defined by adductor tenderness and pain on resisted adduction testing. We start with acute adductor injuries, and again, adductor muscles are the most commonly injured. 18 months ago, number one superstar in the NBA had a groin injury, acute groin injury during a game. First, they did a scan, and they said, okay, it's not that bad. We'll have day-to-day evaluation until he comes back to play. But then they said, okay, it's really not so easy. It's maybe 6 weeks. will need to be careful. And then it goes back to 5 months out of play. And even his colleague, who is not a doctor, who has similar injuries, says, you can't rush on this one. When you have a adductor avulsion, complete tear of adductor longus muscle, usually you can have also some inguinal pathology, like shown on these pictures, which doesn't, you cannot see this on MRI or any other scans. But here on the cadaveric photo, you can see how interconnected all these elements are. And this is also nicely demonstrated in a study by Professor Childers in his cadaveric dissections. And you can see some nice photos there, who is interested. When it comes to adductor longus acute injuries, we have 3 types: proximal insertion, musculotendinous junction of the proximal tendon, and musculotendinous junction of the distal tendon. It's very important, the location of the injury. Recently, Andreas Herner published a paper on our series of conservative treatment of acute adductor injuries, where they grouped MRI stage 0 to 2 in one group, and stage 3, which is complete avulsion, is completely different. You can see that up to 2 to 3 weeks, stage 0 to 2 will come back to play if they finish the complete proper rehabilitation with 3 milestones, which is clinically pain-free, completion of sports training, and then return to play. Overall, 1-year injury rate was 8%, but it's important to note that only 5% in athletes who completed the physiotherapy in the right way, and up to 21% in the ones who jumped to go back to play earlier. When it comes to grade 3 complete avulsions, it's a completely different story, and it's up to 3 months to return to play. But again, everybody came back to play, and if you do proper physiotherapy, it's a low re-injury rate. To cut it short, in real life, when it's insertion, complete avulsion 2 to 3 months. When it's distal, 2 to 4 weeks. When it comes to long-standing tendinopathy type of pain, we know that from Jill Cook's work from Australia, that when you load the tendon, first you have reactive tendinopathy, then if you overload it, tendon disrepair. If you continue to overload it, degenerative tendinopathy. This is very important because it influences the success of conservative treatment. And to make it simple, short algorithm, at 4 to 6 weeks follow-up, if it's enthesopathy, so insertional pain, at 4 to 6 weeks, you evaluate your results, and if there's no improvement, you might think about surgical treatment. On the other hand, if it's more distal, just continue with rehab and you'll have good results. So like in this picture, you can see a couple of centimeters can make a huge difference in prognosis. When it comes to physiotherapy, it's not that simple. You have to do exercise training. And what we do in Aspetar, there's groin exercises, non-groin exercises, and running and sports function. And again, 3 milestones: clinically pain-free, controlled sports training, and full return to play. You can ask me, can they have some pain during exercises, during rehab? Yes, 2 to 3 out of 10 is tolerated, as long as there's no pain the day after, and you give sufficient time, 48 hours, for the tendon to recover. In between 2 training sessions, between two days, you can do some easy jogging or cycling or whatever, but these are the postulates that you follow. And the main exercise is hip adduction, hip flexion, abdominal twisting is what we focus on. Also, because it takes a long time to come back, it's important to have some data to show it to your athletes that they're progressing. If you have a handheld anemometer strength testing, it shows the progress in strength. And also, if you do the Hagus questionnaire, which is translated in different languages, it has a good mark on progression that you can show to your athletes. One more thing that is very important here is that when you treat junior athletes, you have to be much more careful, because insertional tendinopathy is usually pubic apophysitis, because pubic apophysis closes between 16 to 21 years. It's the last one basically to fuse, even up to 26. So you have to be very careful when you load these athletes during rehab. Professor Holm, in his landmark paper in 1999, published in Lancet, showed that if you do proper exercise training for the adductor tendinopathy, you can have 80% success over 4 to 5 months, but still there's 20% of patients who don't recover after 4 to 5 months, which is really high in professional sports. And in recreationals, in home-based exercise programs, as published by our colleague Adam Weir, it's only 50% athletes return to play after 3 to 4 months. So it's not a magic bullet, conservative treatment, there are failures, and then sometimes you have to do something else. So like Nassim Taleb says, risk management isn't about being very prudent and careful. It is about eliminating risk of ruin so that you can very aggressively take non-ruin risks. You know, you would all say that surgeons jump to surgery immediately and they don't care and then don't think about it too much, but somebody has to make a tough decision because it has been shown that in professional sports, for example, Premier League, it's 450,000 pounds per month for each player that is out of play. So you cannot wait 5-6 months and then decide what to do. So when there's no progress in conservative treatment, we have to do surgeries. In this case, for adductor tendinopathy, what we do is adductor longus tenotomy, which is shown to be very successful. In Professor Schilder's series, 42 out of 43 athletes returned to sport after 9 weeks, which is the same what we experience in our clinic in Aspetar. And you can also see the same results in this nice paper from the US, where they showed approximately 8 weeks to return to sport, and the whole the surgical procedure is very well described here if somebody is interested in this. The other part, which is very important for us as surgeons, is inguinal-related groin pain, which is defined as pain in the inguinal canal region and tenderness of the inguinal canal. No palpable inguinal hernia is present, and it's more likely if aggravated by abdominal resistance or Valsalva, cough, or sneeze. So inguinal canal is part of the bigger system, which is all the core muscles working together. And this is inguinal canal is the weak spot basically because this is these are the insertions of all of these muscles. So in some studies it was shown that for example, contrary to common belief, rectus abdominis during Valsalva is not even used that much. The most used muscle is internal oblique, so the lateral abdominal muscles are very important, and as long as with pelvic floor and chest muscles. And you can see that also diaphragm excursions in during tidal breathing or upper extremity isometric contraction and lower extremity isometric contraction are completely different. So you can see how hard the diaphragm works when you have adductor resistance testing. So the whole system works together. Inguinal canal is the weak spot. It is basically formed by 3 lateral abdominal muscles, where external oblique and the inguinal ligament form the front wall and the floor of this tunnel, and internal oblique and transversus abdominis form the roof and half of the posterior wall. And then you have the weak spot, which is the real posterior wall, which gets covered during strain, during the Valsalva maneuver in a lot of people, but sometimes it doesn't get covered, and that's where you can form some bulging or some inflammatory response. In this region, you have some important nerves, which are the genital branch of the genitofemoral nerve, which is below the spermatic cord, ilioinguinal nerve on top of the spermatic cord, and iliohypogastric nerve not so much involved when it comes to groin pain. In real life, it's not so simple like on the graphs, but if you look properly during surgery, you can find these nerves and address them. We know the dermatomes, what we learned from school, which nerve innervates which area, but it has also been shown that, for example, apart from the ilioinguinal nerve that has in 90% of cases cutaneous branches, also genital branch has 35% of cutaneous branches. So it's there's overlapping between the nerves. And also in this nice study from Senegal, it has been shown that there's 16 modes of division of the ilioinguinal nerve, which shows why players suffering from the same basically condition have completely different clinical presentations. Also, one nice picture from one of the congresses that I took. You can see here a common trunk of the iliohypogastric ilioinguinal nerve, and then different bifurcations of the ilioinguinal nerve, and you can see how complicated the story can be. So we know that when the nerve is compressed, it reacts, and there's a fat degeneration distal to the point of compression, like as you can see here, compared to a normal nerve. And also another post from one of the congresses where people show that there's compression neuropathy whenever you have pain with hernia. There are a lot of hernias, they're not painful, and this is the same story when it comes to inguinal pain in athletes. So some of my pictures, you can see here, a lot of people say there's a groin pain, you can have tear in the external oblique aponeurosis. Tear by itself doesn't cause pain. What causes pain is the adhesions below and pulling the nerve that lies right below the external oblique on top of the splenotic cord. This is ilioinguinal nerve here. And then you can have another variation, anatomical variation, where ilioinguinal nerve goes through the external oblique aponeurosis instead of external ring, and it can be pulled in twisting maneuvers. Also here, similar story, you have the kinking of the ilioinguinal nerve at the external ring. So again, it can be pulled during movement. And this is why, for me, posterior approach, post-surgeries, laparoscopic surgeries cannot really address this problem because they can only reinforce the posterior wall, but not this part. You can see what the nerve looks like after surgical release. And again, the genital branch of the genitofemoral nerve, here's the ilioinguinal, is not so easy to find, but if you look hard enough, you can find it and address it because it lies right next to the posterior wall here, the weak spot. So we know that pain can be nociceptive, nociplastic, neuropathic, and in inguinal-related groin pain, there's a combination, maybe a little bit of all of these. And we have basically, for me, two types of patients that present in our clinics. One are patients with nociceptive inguinal pain. It's like deep, vague inguinal pain following sports. So everything hurts after a short period of overload, and usually everything is painful, but there's no bulging, and you cannot find anything in imaging. In these cases, you give them a lot of time for conservative treatment and have to be very patient. But if this doesn't work, we can reinforce the inguinal canal with surgical treatment, and there's also maybe some like dry needling effect on soft tissue healing where we go through with the needle. On the other hand, another group of patients we see in the clinic are the ones who are completely fine in normal life, but they say with high intensity sports, in twisting movements, they have some short lasting pain, few seconds, radiating towards the scrotum or inner thigh, and they describe electricity or burning sensation. This is typical nerve irritation symptoms, and sometimes on physical examination, they're completely normal, and maybe you can find some weakness on the posterior wall on ultrasound. In these cases, you can give them some time for rehabilitation and offloading, but don't play too long because that usually doesn't work, and you can proceed earlier to surgery where we can do the reinforcement of the inguinal canal and address the nerves if necessary. I am proud to say that the first surgery was done of this type in 1967 in Belgrade by Dr. Branko Nešović, very famous. He was an orthopedic surgeon with this great idea to reinforce the posterior wall of the inguinal canal instead of cutting the adductor tendon. The first patient was Milo Manjorić, very famous, still alive, as a witness to this procedure, and he continued to operate patients, famous athletes in the 70s and 80s throughout Europe. What he did, it's a modified Bassini technique, and the difference is in the hernia operation, you open the posterior wall, and with interrupted sutures, you heal the hernia. And in Nešović's procedure, he doesn't open the posterior wall, just approximates the lateral abdominal muscles to the inguinal ligament. In this way, creates different biomechanics here. He was also quoted in the work of Bill Myers, #1 surgeon in the US in this pathology. And also, there are a lot of people still using this technique. This paper was published last year in Belgium, and 10 years results of Nešović's procedure with adductor release. We also published one of his papers out of respect for Dr. Nešović in Hospital Journal in 2012, where he shows his 20 years of experience in this pathology. On the other hand, seeing hernia surgeons, we know that the #1 surgery for non-mesh surgery for inguinal hernias is Scholde's procedure, which is a continuous suture 4-layer procedure. I will not go into too much details because a lot of people here are not surgeons. But Dr. Muschel from Germany did the modification of this technique with small, less opening of the posterior wall and getting better results. And in her hands, 67% of athletes return to sport in 2 weeks. In a comparison study in the US between Bassini and Mushevek repair, in their series, it takes 5 weeks to come back to sport after Mushevek repair and 25 weeks after Bassini repair. So, courtesy to Dr. Mushevek, some of the videos, you can just see here, finding of the genital branch of the genitofemoral nerve, which is here, next to this vein here. And then you can see here that there's no hernia, there's just some posterior wall weakness, peritoneal fat bulging through the posterior wall. And the repair is very elegant, without the mesh, just 2 sutures. And it's important to open the posterior wall a little bit where you can catch the fascia, which is very solid and very important for preventing future hernias. Again, one of the last steps is lateralization of the rectus abdominis muscle. And like I said, you completely change the forces in this area with surgery. You can see the repair very solid and you don't need a mesh. So even Dr. Mushevek says 2 weeks is enough to go back to play, but it's only in 50–60% of people who are without pain and at full exercise capacity at 2 weeks. But still, at 4 weeks, you can see 80% of people will come back and return to their sports with some degree of pain. Why we have pain? Because it's usually, there was pain for a long time and the pain can persist as a result of sensitivity and not tissue damage. So you can be safe and continue progressing in physiotherapy and pushing them to go back. We published a paper on the rehabilitation, return to play following surgery, and it's a 4-stage based rehabilitation program. So don't focus on time, focus on proper progression during physiotherapy. We also know that from the nice paper of consensus statement on return to sport by Claire Arden from 2016, that return to sport is a very complex thing. You have to take into account a lot of components. And like they say, the best math you can learn is how to calculate the future costs of current decisions. So be very prudent when pushing patients back to play. So take home message is know your anatomy, nice diagnosis and correct terminology. Structure strengthening rehabilitation is important, criteria-based progression. Use questionnaires, strength values. A little bit of pain is okay. Give the tendon sufficient recovery time. It has to be sport-specific tailored rehabilitation. Adductor enthesopathy maybe needs surgery. When it's a little bit lower, no surgery. If it's neuropathic pain in inguinal canal, early surgical decision. Nociceptive pain, you can delay surgery. Again, adductor longus tenotomy when conservative exercise-based treatment fails. Only in enthesopathy cases, not in tendinopathy. Reducing tension in the pubic bone, this is the goal. And there are superior results published with professional compared to recreational athletes. And we expect return to team training at 6 to 8 weeks. And in inguinal repair, when conservative treatment fails, this is for me the ideal repair for posterior wall weakness. You can also do neurolysis or neurectomy in this case. We operate only on symptomatic sides, not on both sides if there's no pain on the other side. And we expect return to team training at 3 to 4 weeks. I'll just show you an example. An athlete 1 year out of play, different treatments, and then the national team player in the golf, and had all 4 surgeries at the same time, bilateral adductor tenotomy, bilateral inguinal repair, and this is what at 5 weeks what it looks like. So running pain-free after 1 year, which is for us really great, and we are happy when we see this. It's not always like this. Sometimes you always, of course, you have some problems, but this is our goal. So like we say, it's what you learn after you know it all that counts, according to famous coach and leader, Dr. John Wooden. And the greatest enemy of knowledge is not ignorance. It is the illusion of knowledge, according to Stephen Hawking. So we are happy to share all our knowledge that we have in Aspetar on Aspetar YouTube videos, Aspetar Sports Medicine Journal, and also you have for groin pain, British Journal of Sports Medicine Groin Pain Edition from 2015. And with this nice picture of Belgrade, I am open to all the questions that you might have. Thank you.
Okay, well, thank you, Dr. Vučković, for everything. It was really lovely lecture. You can stop sharing your screen if you want with this last slide, but it's really beautiful for all of us that has today woke up in Belgrade. So
We can leave it.
yeah, so for all the participants, you can now use the raise hand option. So when you click on manage participants, you will get, you will get the option raise hand. And if you want to ask a question, just click on that option and I will get the notification that you want to ask something, Dr. Vučković. We have something on chat. Okay. So we have from Bruno Lori the question. So thank you, Dr. Žarko, for this very complete topic. Why don't all visceral surgeons have this vision? So this is the question that we got in chat. Okay.
Thank you, Dr. Bruno. Dr. Bruno is one of our orthopedic surgeons in Aspetar. I'm happy to have my colleagues here listening to this. So even orthopedic surgeons, lower limb surgeons would like to know what we're talking about. And why the difference is a lot of people treat things that they don't understand. A lot of inguinal surgeons focus on hernias, and you know, when you have a hammer, everything looks like a nail. So on the other side, I have 15 years of experience as a team physician and huge passion for sports and loved sports all my life. So, and I thought I would be an orthopedic surgeon when I was a kid, and life took me through general surgery and then brought me back to an orthopedic clinic and sports medicine. So basically you cannot escape your destiny. You get what you ask for, and this is how you have to approach this. It's a multidisciplinary thing. It's you have to I'm grateful for 10 years of experience in Aspetar with listening to all orthopedic surgeons, sports medicine physicians, and physiotherapists who helped me develop my point of view.
Well, thank you for the answer. We also have one hello from Jovan Zlatković. So hello to everybody, especially for Žarko and Sanja from Dr. Nebojša and me. So this is just like saying hello, but I really want to ask all the people that are participating in this lecture to raise their hand and ask something. I mean, we have one expert here on the groin pain. So probably you had some opportunity to felt it yourself or to have some athlete that is suffering from this. So ask if you want anything to Dr. Vučković. Okay, we have a hand from Miloš Bojević. Okay, Miloš, you can now ask your question.
Can you hear me?
Yeah, we can hear you.
Yes.
Yeah. First of all, I would like to say hello, all the participants, and thank Dr. Vučković for this great lecture. It solved many doubts related to groin pain, especially its etiology. I would have a few questions for Žarko, so here they are. First, in your earlier lectures on this topic and today, you talked about the nature of inguinal groin pain and how pain can be nociceptive or neuropathic in nature. In your experience, can drugs be used in case of neuropathic pain? I mean, primarily pregabalin and gabapentin as drugs that are normally used in chronic neuropathic low back pain. And do you think they can be used as a part of conservative exercise-based treatment in a way?
Hi, Milos. Thanks for your lecture, for your question. It's a great question, and what I have to say on this is these medications are widely used when you have chronic post-operative pain. So, and chronic post-operative pain in hernia surgery is a hot topic now. Recurrences are not that much anymore, but a lot of people, especially with using meshes in not the right way, and not addressing the nerves, you can have severe chronic post-operative pain. In these cases, if you don't address this pain immediately with reoperation, usually they're treated for at least 3 to 6 months with these medications because it's really high level of pain. In inguinal pain in athletes who are not operated, the level of pain is not so strong. So you can usually keep it under control with some simple medications, but if you offload them, the pain is not so strong, and with rehab, usually they have good improvement, at least initially. So now we don't know if this will be a complete resolution of symptoms and they will go back to play, or we need to do surgery at one moment. But I wouldn't go in these cases because, like we know, in the US, there was a huge opioid crisis and addiction because of wide usage of these medications, and I really don't use them. So completely different thing when you have a nerve entrapment after surgery, which is severe pain and affects really everyday life. These people are, I mean, recently I saw on one of now during the COVID epidemics, one of online presentations of a colleague in New York treating also groin pain and the top hernia surgeon, and treating a patient for chronic post-operative pain, multiple surgeries which were not done in the right way, and then the patient committed suicide before ending of the treatment and before having a final proper operation. So these are completely two different things, and we, in my opinion, should stay away from these medications. It's better to do surgery earlier and to address all the problems than to go to this path, which is really dangerous.
Thank you for your answer. Can I ask you another one?
You can ask a million questions. We can stay for an hour. So please, guys, feel free, all of you.
Great. Since the outcome of the operation is very important to you as a surgeon, and the follow-up of the patient does not end after leaving the operating room, but lasts in that sense during rehabilitation period, how important is the post-operative period, and whether the principles you talked about in your Get in the Box lecture, I found it on YouTube, related to strengthening the core, are applied post-operatively? Also, one of your team members, Andreas Cerner, you've mentioned him before, spoke at Swiss Sports Medicine Conference 2 years ago about the rehabilitation of groin injuries, and then presented the paper by King et al., a Dublin group of scientists, where they talked about so-called intersegmental control as a possible approach to conservative treatment. To summarize, do the principles we use for non-surgical treatment also apply to post-operative recovery?
Yes, another excellent question, and I agree. The work from Dublin is very important, but this is for me something that is more related to prevention of injuries and for long-term follow-up and correcting all the problems. Like I say, inguinal pathology is related to the whole core system. So it's very important to address all the muscle deficiencies. But when we have an athlete who has pain in a certain moment, all these principles cannot give results in short term. So this is something you cannot build your body for sports in a few months. It takes years. So surgery is just the first step when we need to do it. And I'm happy to say that I witnessed a lot of patients who I thought for sure they will have surgery like between 12 and 18 months without playing football, and from neighbor countries here. And after 4 weeks of proper physiotherapy with our team, which is really dedicated and has a huge experience, all of them, 5 of them recovered 80% in 4 weeks. So the first step is proper rehabilitation. That's why I never operate anyone. Even if I'm like 99% sure they will have surgery, I would give them a couple of weeks, at least 3 to 4 weeks of rehab. And then on the other hand, like I said, if it's this typical neuropathic pain, which is a few seconds of pain, nerve irritation, burnings, electricity sensation, with some twisting movements, and they're completely fine. Otherwise, we had patients who after 5-6 months and correcting all the deficiencies and returning to play whenever they're just about to go back to play, and they go to real sports or football training and heavy exercises, they experience the same pain again. And then you do surgery, and in 6 weeks, they're completely resolved. So it's that's why I said the ones who are overloaded, like nociceptive type of pain, this is usually patients who had severe training sessions, for example, after a summer break, and their body was not prepared to the load that they were subjected to. And these guys, with offloading and rebuilding strength properly, in majority of cases will end up not having surgery. On the other hand, the ones who have nerve irritations, it's some anatomical variation of the nerves, or it's the patients who had multiple injuries before, and then they have some adhesion, some inflammatory response. That their external oblique aponeurosis is much more fibrotic and much harder than regular hernia patients who don't do sports. So you can understand. So many times when we operate, you see these adhesions are so strong that you have sometimes to do the sharp dissection of the adhesions to free the elements. And then we can understand how much, and usually the nerves are thickened, and you can understand how much these nerves are pulled with every movement that they make, especially, for example, football, crossing the ball from full sprint or something like that. This is a heavy load in this region, and that's when the nerves get affected, and that's when you have to do surgery. And many times we do the neurectomy because, like we say, we don't want to have these, because even after surgery you have some adhesions, and it's never the same like before. So it's a tailor-made decision according to each patient, but these are just like rough guidance, what I showed, how we need to approach these patients.
Thank you.
Okay, thank you, Milos. So we have some comments and questions here in chat. So first from Emmanuel, good job, brate. So we have greetings from Thessaloniki. So Nemanja, if you want, you can turn on the microphone, or I can ask the question from chat here. So thank you for a great lecture, Dr. Vučković. I'm interested why you don't use Liechtenstein mesh repair instead of Schultes repair, if I pronounced it correctly.
Perfect question, and thank you for asking. I wanted to basically, I had some slides also prepared to incorporate in this presentation related to this, but then it would take too much time, and probably I can have a 90-minute presentation on groin pain, not only 35. According to Professor Schumpeli, who is a legend in hernia surgery in Europe and honorary president of European Hernia Society, and his paper from 2001, where he presented his opinion on this topic, saying that, and I'm not talking about inguinal pain in athletes, I'm talking about hernias. The industry is so strong and pushing for using of meshes because a lot of money is involved. So he says that also many, when you use a mesh, it's prosthetic material and it causes some different problems later on. They're very rare, and Liechtenstein repair is a valid procedure when it comes to hernia repair. And even I use it many times. But when you have a really small hernia, which is, I don't want to bother you, according to hernia classifications, which is type 1, very small, less than 2 centimeters, and especially when it's lateral hernia, which is the internal ring and not a big deficiency of the posterior wall, you can have a proper repair with non-mesh techniques. And I would just say, even Bassini, who is the father of hernia surgery, who started this more than 100 years ago and revolutionized hernia surgery, at that time operated probably huge hernias only. Nobody came for surgery 100 years ago with really small hernia, and he had 80% success without using mesh. So when you have a big hernia, big weakness of the posterior wall, I would be the first one to put the mesh, especially because we are talking about systemic disease, collagen deficiency, and many times it's multiple hernias, bilateral, inguinal hernia, even umbilical at the same time. In these cases, and you have also risk factors for recurrence, which are obesity, steroid use, diabetes, older age, etc. So when you have these risk factors and big hernias, you use Liechtenstein procedure. On the other hand, with athletes, when you want to have slight bearing of the tissues because of the layers of the muscles, to have less tissue reaction, less adhesions after surgery, and if you and you know what the difference is when you reoperate patients with mesh and without, you can see that this is more elegant procedure. And if you ask me, in young people without hernia, with a small weakness of the posterior wall, with some nerve irritation, why would you put the prosthetic material if you can achieve the same results as published in a lot of studies without using a mesh. A lot of surgeons use Liechtenstein procedure because this is the most widely used procedure for hernia patients. But whenever you use a mesh, there's a much higher risk of later incorporating the nerve into the scar tissue around the mesh, and then you can have chronic pain problem. Another study published by Ali Shim from Manchester, who is the main author of the British Consensus Statement, and Professor Payanen, they did a multicentric study comparing total extraperitoneal repair, which is like a posterior approach, putting the mesh between the peritoneum and the fascia transversalis from behind in an endoscopic way, and compare this with minimal repair of Mushevec. They show they have the same results. So even return to play time, now good surgeons, if you do proper technique, it's you have similar results. But again, I would ask a question: if we have the same results, why would you put extra foreign material in the body, especially with young people who might have some different surgical procedures in the future? So that is my take on this. Of course, hernia surgeons are only mostly focused on having no recurrence of a hernia, and I'm a general surgeon more focused on sports. And if you ask me, even in my age, which is 50, I'm like borderline on this age category for recurrence risk. I would have a shoulder repair on myself, and then if there's a recurrence, which is less than 3% chance, if it's done properly, then put the mesh if I get a hernia again.
Okay, thank you. So I see that Milos still has a raised hand. So Milos, do you have some more questions or not?
Sorry, it probably stayed raised,
Okay.
but I have questions, of course.
So, we also have, okay.
It's unique opportunity, but I think there are also questions from the chat, so people can ask before me.
So okay, so thank you. So we have on the chat from Gert Mandrovic from I think Latvia. Thank you for these great lectures. Do you think PRP plays a role in adductor-related groin pain?
Great question again. To be honest, I don't use it because a lot of studies in hospital that we did mostly on hamstring injuries doesn't show any benefit. There's also studies done on lateral elbow pain that also doesn't show too much benefit. I'm sorry that we don't have our colleague from Amsterdam, Hans Stoll, who is a big opponent to using PRP because it's a pretty expensive tool. I'm not really against it, because if somebody wants to use it in their practice, it's fine, because it doesn't give too many adverse effects. It's a natural thing, and but I don't really believe that that can replace proper exercise-based rehabilitation in terms when it comes to adductor injuries. And like I said, we have really good results in getting people back to sport without it. So unless there are really good scientific studies showing big difference, I wouldn't change my practice. But like I said, it's up to everyone to decide what works for them. And sometimes it's also a placebo for the athletes. And if the placebo works and brings them back earlier, it's fine. It's perfect.
Okay, thank you. We also have one more question from Git. So what role pubic bone marrow edema plays in management of groin pain?
In my view, pubic bone marrow edema is a functional adaptation, and this is what we see on MRI. This led to having the term osteitis pubis coined earlier in the past when it comes to groin pain, because people didn't really know what was going on. So they would do an MRI, they see something on the pubic bones, and they would say, okay, it's osteitis pubis. It's proven there's no infection or in this sense. So osteitis in this sense is a wrong word, but pubic bone marrow edema for me is a adaptation to a lot of stress, like it showed from Professor Painen's work in Finland. 48% of the athletes have pubic bone stress, asymptomatic athletes. But On the other hand, what they showed also is when it's grade 1, very mild pubic bone stress, this is what we see in asymptomatic athletes. In athletes with groin pain, very often you will find like grade 2, grade 3, more severe bone stress. But again, the main problem doesn't come from the bones. It's the soft tissue from above and below inserting at the bones, which is causing this adaptation. And this is just a signal for us that something is going on. On the other hand, it's shown in different studies that, for example, if you do MRIs of tibia of marathon runners after the race, you'll see a lot of them with bone stress of the tibia. And that doesn't mean that it's a stress fracture or something. It's just adaptation to physiology. Even when it comes to studies on muscle injuries, it has been shown many times that using MRI to evaluate return to play is not useful, because a lot of athletes will have some positive findings on their muscle injuries a long time after returning to play without any problems. So clinical picture and the clinical findings and proper follow-up in this way is much more important for me than bone stress.
Okay, thank you. So we still have questions here on chat, so people don't want to ask by themselves. Okay, from Lazar Michita, what are the experiences with this type of injury in children, so 12, 15, 18 years old, and does the treatment protocol differ? All the bearing in the mind that children are increasingly forced into intense physical activity during the period of growth. So Lazar is a volunteer at the orthopedic clinic Banica. So this is coming from...
Great question. Thanks, Lazar. When it comes to children, you have to be more cautious, and the main thing is offload them and don't push them that hard. In my point of view, I would examine them. If there's a hernia present, okay, you can operate on the hernia and resolve the problem. But everything else, give them sufficient time to recover, and it's more important to talk with their coaches and especially with their parents, because everybody wants to have a new Djokovic or Luka Doncic in their house and push the kids over the limit too much. As a parent of 3 children who are very active, and with my knowledge of sports, I would always take kids out of play and give them enough time to recover. And I always tell them, when you have in the clinic young patients and very enthusiastic parents, I always tell them that they need to play for the next 20 years and not only for the next 6 to 12 months. So 2-3 months in this sense doesn't make a big difference. And also in my presentation, you could see that I mentioned pubic apophysitis, which is also you have to have in mind when it comes to adductor pain with groin athletes, because adductor related groin pain, because this is something that you treat similar to osgood flutter. It's offloading, very careful return to play, load monitoring, load management, pain monitoring daily, and as soon as the pain increases a little bit, you take them out, and this is like a very sensitive game, like walking on thin ice. But I would never rush into surgery or any invasive procedures with children. Just give them enough time to recover, and usually they do good.
Okay, thank you. We also have on chat the question from Dr. Bojan Bukva, so the orthopedic surgeon from Tiršova. What are the histopathological findings in genitofemoral nerve neurotomy and indications criteria for this neurotomy? I probably pronounce it a little bit bad, but I'm not a surgeon. So.
Neurotomy doesn't matter. Yeah, I understood the question. Thanks, Bojan, and happy to hear from you again. Good friends. Dr. Mušovek in her series in Germany did a histological analysis of nerves after neurectomies, and in the huge majority of cases they showed that there is fat degeneration. So when you have posterior wall weakness compressing on the genital branch of the genitofemoral nerve, I mean, it's difficult to see the macroscopic changes during surgery on the nerve. But if you have clear symptoms of pain, electricity type of pain shooting towards the scrotum, where is the dermatome of what we expect from the genitofemoral nerve, even if it might be overlapping from some other nerve, I wouldn't risk to operate the patient and then he goes back, and if you save the nerve, he has the same problem again. In hernia surgery, there's a big debate. A lot of people even propose prophylactic neurectomies of ilioinguinal nerve or genital branch just to reduce the chance of having post-operative pain. And when you have an athlete coming to your clinic with inguinal pain and no hernia, and then you operate a hernia, do a hernia procedure and leave the nerve, and he has the same pain afterwards, I don't think that anyone would be happy. So it's not an easy decision, but from my experience and also following patients from Dr. Mušovek, some of the ones that we did together in Aspetar, after surgeries, nobody really ever complained about this loss of sensation after neurectomies, because these are sensory nerves, not motor nerves. They don't affect any function. So a little bit of, you have with every surgery, even in orthopedics, whenever you cut the skin, you have the superficial nerves that are damaged, and you have a little bit of desensitivity in this area. It's a little bit bigger after neurectomy. It usually returns, recovers up to 80–90%. It takes up to 12 months. And for years later, you can have a little bit of discomfort when you touch the skin. But like I said, people usually don't complain after this, but they really complain if they have pain after surgery. So, which is why they came the surgeon for. So, like I said, it's a decision that has to be made during surgery. And when you see the nerve and you can dissect it easily, I would do it prophylactically, basically, just to eliminate the risk of having pain again.
Okay, so one more question arrived here on chat. So it's from Filip Milanovic. He is also the volunteer at the Children Orthopedics in Tiršova. So thank you for such an interesting lecture. What about femoroacetabular impingement as an etiology factor of groin pain, both in children and adults?
Thanks, great question again. Well, femoroacetabular impingement, like I said, we have the defined clinical entities, which is the 4 groups. And then the second group in our consensus is hip-related groin pain, which is really in close proximity. And whenever you evaluate the patient for groin pain, we have to do a proper hip examination and to rule out hip pathology. It's very rare in our area here in the Middle East. There are etiological variations proven by, in some studies by our other physiotherapist colleague who used to work with us in Aspetar, Andrea Mosley from Australia, where in Asia altogether you have less prevalence of femoroacetabular impingement compared to Europe or North America. On the other hand, I think that sometimes it's really overdiagnosed because, like I said, if the skills of the treating physicians are not on the certain level and they don't really know what's going on, and you do a lot of imaging, then you can find FAI on X-rays or on the MRI, and even some lateral tears, and jump to conclusion that the pain comes from this. On one of the papers that I presented here in the presentation from USA, you could see that up to 77% of asymptomatic ice hockey players have positive findings on their hip MRIs, and like I said, without any pain. So unless there's when you do the Fader and Faber tests and they are positive, I wouldn't rely on imaging and treat FAI. On the other hand, you have a certain group of people who have really hip-related problems, and then after long, so you can do physiotherapy, then you can go to arthro MRI of the hip with contrast. You can inject local anesthetic and do the examination immediately after, and then you can see if there's any improvement in pain. So to differentiate between interarticular and extraarticular pathology. And if this is positive and speaks in terms of interarticular pathology and positive findings on imaging, then we refer them to hip surgeons who have more experience, and then it's up to them to make the decision if they need to do surgery and when. There are a lot of positive cases after surgery with a big relief, but also there are a lot of, now it's in the groin pain, it's really, this is a great question because it's the next hot topic, because a lot of papers are coming out regarding hip-related groin pain and physiotherapy versus surgery in this area.
Okay, thank you very much. So we also have greetings from Buko. So thank you, Žarko. Regards to you and Groin Pain Center in Aspetar. So he's also sending hello. Okay, is there any more questions for Dr. Vučković? We really had a live discussion here. So as a moderator, I'm really satisfied with this lecture today. So anybody like raise hand or write on the chat?
I would like to add something to Miloš's question. I just remembered about the opioid medications for groin pain. Like I said, I wouldn't jump to this. And even when you have sometimes neuropathic pain after surgery, the first step, which is better, is like a local infiltration of the ilioinguinal nerve, ultrasound guided, or if you're skillful enough, even without, you can do a nerve block and see if, like a diagnostics with lidocaine, and see if there's any improvement. And then if it comes out positive, then the next step would be like a depomedrol injection with lidocaine, and many times it can have at least a temporary relief for 3 to 6 months. So this would be the next step in these cases before going to surgery. Sometimes the pain is resolved, so you always give the patients a chance to recover without surgery. If the pain comes back, okay, then we proceed with neurectomy. And Miloš, you said you had a number of other questions, so feel free.
Yes, I have a few of them more. You've worked on a longitudinal surgical study at Groin Pain Center in Aspetar about inguinal-related groin pain, and the question was, is it a tendinopathy or a collagen deficiency, if I'm not wrong? Can you tell us something about it, and what are the results?
Well, this was the idea for a study that we at the end didn't do because it was difficult regarding the number of patients we had here. It has to be maybe done in a center with higher volume of patients, but that was a result of discussion that we had in our groin pain center, because like I said, all my colleagues are physiotherapists, sports medicine physicians, and they're focused on tendinopathy type of pain and injury muscles, tendons. And at the same time, since I come from the general surgery background and following all the hernia conferences, we know that the hernia, like I said, is a systematic disease, which is a deficiency of collagen, and collagen 1 to collagen 3, strong and weak collagen ratio, which is changed. So for me, it would be a nice question, and it also relates to the question about Lichtenstein repair with the mesh. So if we can prove that there is no collagen deficiencies in these patients, then all the meshes should go out and wouldn't be into consideration. On the other hand, if somebody proves that even in these patients with this bulge doesn't appear as a result of an injury and weakness, progressive weakness of the posterior wall because of the altered function of the muscles in this region, just because of a lot of stress that they're subjected to, and then this weakness, you have proper collagen, but too much stress breaks it, and you have a problem that we solve with surgery, then it's these patients would be one type of patients. If, on the other hand, we can show that all these patients that we operate for inguinal-related groin pain end up having collagen deficiency, then we can discuss, should we operate earlier, and maybe then the proper discussion should be, should we use meshes or not? But then it's not so simple. Even with collagen deficiency, then we will have to do prospective studies between the two techniques and see if there's any difference in results. And again, if there's no difference in results, even with that, I would stick with non-mesh procedures. So it's a great question. Thanks for reminding me of this.
Yeah, you're welcome. And just one more, I will finish with this one. In one of your lectures at the hospital handball groin injury, I think workshop, you mentioned the work of Japanese group that demonstrated variations in anatomical distributions of pain and anatomical variations of inguinal nerves in general. I think there was a slide today in lecture also. How difficult it is for you, for a surgeon, that fact, and whether there are any diagnostic methods that can visualize nerve pathways like MRI tractography or something else. I'm not a surgeon. This is just for curiosity.
Again, great question. It is not easy. We can just basically guess in our clinics and try to find out which nerve is involved. I will go back to chronic post-operative pain after surgeries, and a lot of work was done on this and with neuropathic pain. And in the 90s, they did some studies on this. There was one proposal to try to guess which nerve is involved and just to do neurectomy of these nerves, and usually it's double neurectomy. And these surgeries gave 75% of good results compared to triple neurectomies, where you also remove the iliohypogastric nerve. But again, I'm talking about hernia patients with mesh procedures, and then you don't know which nerve is really affected and how much. Triple neurectomy gave, in different studies, 95 to 97% of success. There is a hernia surgeon in Mexico, Rigoberto Alvarez, who came up with a fantastic idea, and this is widely quoted in hernia conferences now, with which is called dermatome mapping. And this can be useful in treating athletes. He says you only need 3 markers: black, red, and blue. One, red will show pain, blue will show the sensitivity, and black will show normal findings. And you can like draw different dots marking points in the inguinal region, and you can, a lot of times you can see the potential distribution and involvement of different nerves. And at the same time, with this, you can follow up recovery after surgery, because if you take a photo of this, of certain patient, you can see, you can mark them again throughout rehabilitation, medication, and then after surgery, and see progress and if the pain is resolved or not. So this can also be used in our patients with groin pain, which is inguinal pain. And it's another way to show the patients if there's progress in treatment, because if the dermatome which is affected is slowly getting smaller, then maybe you can wait a little bit longer. So again, great question. It's really nice. Like I said, there's so many things that you can present, but such short time for a presentation. So
thank you for your answer.
Okay, thank you, Milos, for all the questions. We have one more here on chat. So one more from Philip. What if the groin pain goes together with gluteal region pain, piriformis syndrome? Question mark.
In my opinion, it is a completely different entity, but what is important when it comes to gluteal region is that gluteus medius muscle is the main abductor. So in rehabilitation, you have to work on gluteus medius and the adductors at the same time, and to have balance between the muscles. So of course, if somebody with groin pain also has piriformis pain, and you have all, of course, to differentiate between, is it piriformis, is it the injury of the sciatic nerve on some other level or compression, and which, do you need surgery, do you need rehabilitation? In many cases, of course, the huge majority only rehabilitation. You can address, of course, you have to address this with physiotherapy. So we just focus here on groin pathology, but when you see a patient who has groin pain, he can also have some other problems, and during rehab, you have to address all of this. And not only this, even when, like I said, with return to play, you need to assess the complete body function and biomechanics. And you don't want to, I don't want to have somebody who had inguinal pain and I operated on him, and 1 month later he goes back and has an ACE injury. So these are all things that have to be taken into account. So do your proper examination, and whatever you find, it has to be treated.
Well, thank you. So for now, there is no more questions here in chat. So somebody maybe to raise hand. No. Okay, we'll mute with Boris. So nobody for now. Okay, we already discussed this before we met officially here for the lecture. So I read about this Doha agreement that you had in 2014, and it was really interesting for reading because like for one clinical entity, you had 22 different names and diagnoses coming from 24 leading people from the groin pain in athletes. And you actually made some tremendous work there to synthesize everything is like, like 3 sub-headlines. And you also followed this agreement with your study from 2017 on 100 athletes here in Doha. So you made one epidemiological study and showed that the most common cause of this groin pain was the adductor related, but mostly patients were football players and males. So you implemented these new definitions and new nomenclature in your work, but do you think that these new guidelines actually help to other physicians on the field, so they are more sure how to distinguish what is the cause of the groin pain, to make a decision to treat it like conservatively or to send the people to you or to your colleagues? So it's actually, this helps to people that are in these front lines with athletes. And what are some further plans due to this terminology that you developed in Doha?
Yeah, again, thanks, Bilja, for a fantastic question. I'm really happy and proud that I had the chance to be part of this group, and this Doha agreement is basically the baby of my dear colleague Adam Weir, who is a fantastic sports medicine physician dedicated to groin pain mostly. And like you said, we came together, and all of us coming from different backgrounds, had different ideas about groin pain. And we came with this terminology, which, like I said, defined entities, these 4 groups, they are not diagnoses. This is just like some terms that we can use for easier communication. So at least to group our patients in different groups, and then we can compare results. It's useless to compare when you just say groin pain, and if you compare somebody with inguinal pain with somebody with adductor pain and someone with a hip problem. So it's completely different things. At the same time, I'm also happy to say that working with Adam, we continue to work together. And now our idea is that even though, so first, just to clear this, like I said, it's not diagnosis, and the best comment that we had during this discussion came from Professor Karim Khan, who said, okay guys, this is now, we have Earth, and first we need to name the continents. And once we agree, then we will name different countries. So this is what we have at the moment. Now, work that lies ahead of us is to go deeper into getting to different really diagnoses, and maybe every patient will have really clear pathologic entity that we can prove. At the same time, I'm even not sure that everybody, even from the group that participated, really accepted the terminology, and I don't know if they use it in everyday life. And I'm sure that it would be too idealistic to accept that everybody really changed what they, how they worked all their lives and how they jumped to a different terminology. So now our goal now at the moment is we are in the process of re-evaluating this, doing another questionnaire with the initial participants of the first study, and to see if they really use the definitions that were proposed, and if they have some ideas how this should be changed or made better. And once we finish this, the next step would be to do the same with different practitioners around the world, sports medicine, physiotherapists, because I can see in many conferences now, and I'm really happy that a lot of people use these pictures and these terms in their presentations. But it's one thing to use it for a presentation, and maybe you don't use it in your everyday life in your clinic and when you talk to your patients. So now we have like 3-4 steps to evaluate 5 years later if this is really implemented or not. And there's no use of being happy about a perfect paper if nobody's using it. So on the other hand, if we show that people are using it, but we can make some improvements, this is a step forward. So yeah, great questions, and we really think about this a lot.
Well, thank you for your answer. I hope that actually a lot of people actually accepted this this terminology, because it's for now it's really clear and address us in probably the right direction when we discuss this growing pain management. Okay, so there is no more question on chat, or I think nobody is raising their hand anymore, but this was really a great discussion that we had here. So thank you a lot that you found some time for our audience here in Belgrade, but also we have like people coming from really different parts of the world. So we have from Latvia, from Thessaloniki, so you from Qatar, here domestic in Belgrade. So really worldwide webinar. I would also like to ask everybody that is present now here for the next week lecture. So next week, the lecture will be at 6 p.m. So now 5:30, so then 6 p.m. And it's going to be the lecture by Professor Roland Barr. So Professor Barr is a professor of sports medicine in the Department of Sports Medicine at the Norwegian School of Sports Sciences, and the chair of the also Sports Trauma Research Center. He is also the chief medical officer of Olympiatoppen and chair of the medical department at National Olympic Training Center, and also head of the Adductor Sports Injury Illness Prevention Program. So the lecture that he's going to provide us is under the headline, the Norwegian Olympic and Paralympic Screening and Monitoring Program. What is it? Why do we do it? And does it help Norway win the medals? So that will be the plan for the following Thursday. I will also send you invitations like for this previous 4 weeks. And I'm really thankful to all you guys for such a big number of questions, and for Žarko that actually had the patience and will to answer all of them. So I think this was like one of the best discussions that we had in this forum until now. So stay well, and we will see each other in a week. So thank you once again for everything.
Thanks for organizing. It was great. It was really a pleasure. And thanks, guys, for all the questions. Please, via Bilia, we can share our contacts and emails, and whatever you need to ask in the future, we are really happy to help. So stay safe, and best regards from Doha.
Bye.